Thanks. I was told that marketing was 10% reality, 90% perception, actually. But I've been around nearly as long as you, and really, in some ways, my work is done. HIV is over. It's the end of the AIDS epidemic, and it's really been achieved, or some of it's been achieved, by going down targeting, trying to go down the so-called 90-90-90, getting 90% of the population diagnosed, 90% on treatment, and 90% virally suppressed. And you can look all around the world and see different countries, different cities, which have achieved at least one of those. This is the data from London. London's achieved 90-90. Sadiq signed up for it. He was very keen to sign up as a fast-track city as soon as we reached 90-90-90. He wouldn't do it before, interestingly enough. But there's other cities, such as Amsterdam, have done it. And I've broken this already. And actually, if you look at the United Kingdom as a whole, the figures that came out on Friday for World AIDS Day show amazing results where throughout the UK, and that's England, Scotland, Wales, Northern Ireland, achieving really high rates of 90-90-90. And it's not a thing just for the resource-rich world, it's also the resource-poor world, such as Botswana, and it's going to be an eradical disease like smallpox, Rint virus. It is something where we can actually achieve, if not eradication, control in the majority of people. The problem with all numbers, and that's why I'd go against your view about looking at numbers too much, is numbers often hide the truth. Or perhaps that's what you were actually getting at, these numbers hiding the truth. If you look at the number of people living with HIV globally, it's huge. The number of people who can get therapy, even in Europe, is relatively small. The number of people dying from HIV are being more than replaced at 2 to 1. By new diagnoses. So you have to be very, very careful when you look at the 90-90-90 cascades as saying, is it reality or is it perception? Certainly, I can't see these figures. Oh, it's down here. Oh, God, how stupid of me. If you look at, despite us being able to control the epidemic, actually new infections are growing much more than we would like. And if you look at areas such as Asia, Eastern Europe, there are new epidemics of HIV infection. So when we talk about this kind of cascade, you can't really go down that cascade unless you also talk about prevention. All right, so you can't talk about getting people diagnosed, getting them on treatment, getting them successfully treated, unless you also talk about prevention. And it's a shame in this country that we can't have access to pre-exposure prophylaxis, which, if you look at the evidence, works, but we continually say we need more evidence. We really need to look at putting treatment hand in hand in prevention. So the first part of actually achieving the cascade is getting people to get diagnosed. And of course, everyone can put up barriers. There are barriers from clinicians, there are barriers from patients, and we need to overcome them. Not talk about the barriers, but the solutions. We need to empower people to actually, and this is what we've done, to self-manage their testing. We need to take HIV testing, or what we've done is take HIV testing out of the GU HIV clinic, and we've actually encouraged people, as you will see, not just to test once, but to have regular testing. And we also need to actually make sure that traditional services, places that people go all the time, the GP, emergency medicine, is where they are actually going to get tested. And that means all about removing stigma. And it's about removing stigma. In 1984, when I first worked in HIV, my mother told me it was terrible that I'd get infected, I shouldn't touch these people. That's what it was like. And we've still got stigma within HIV. And it's amazing if you look at issues of stigma, and I'm sure you have it in hepatitis C as well, how big stigma is. Even if you go and look at GU clinics where people are supposed to go for their care, some individuals still feel that they're being stigmatized by their HIV diagnosis. So we need to change that. And what we've done, I've been working with a guy called Alistair Hudson, is actually, instead of being critical of stigmatization, is actually look at areas where individuals have not shown stigma. And so we're actually asking patients to say, who's got a really good GP, who's got a really good dentist, and then award them in some way for that. I think the other issue which really has changed the way we've treated HIV is being able to diagnose through new testing strategies, point-of-care testing, laboratory testing, home HIV tests. You've probably seen all the posters all over London at the moment about just having a needle stick prick and you'll know your diagnosis. This is all about testing weeks, and testing weeks are ridiculous, all right? Don't have testing weeks. We should be testing all the time. Testing weeks just encourages people to say, I've done it for a week, tick box exercise, and not move on. So we need to actually test all the time, and that means going into the populations who are at risk. So there's been great work going on, going into where intravenous drug users are, going to saunas, clubs, and encouraging testing in those areas. And this is a fantastic bit of work done by the Martin Fisher Foundation, who was one of the leaders in HIV, who died unfortunately, but they're putting these vending machines for HIV tests in saunas, in clubs, so you can actually go in and get your test yourself before you get up to any action in these places. All right, going to the emergency rooms and getting people tested. You know, looking at indicator diseases. We all know hepatitis C is associated with other things. HIV is associated with other diseases. So actually encouraging people who have one of these indicator diseases to be tested. All of those are successful, but all of these still fail. These are 3 publications from this year showing that individuals aren't being tested when they go for medical advice with clinical indicators, aren't being tested in the emergency room, aren't being tested when they have a sexually transmitting infection. So still, there's a lot of work to be done, but that's the kind of thing we want to do. Certainly, if you look at homosexual men in the United Kingdom, there has been a fall in the number of new HIV diagnoses. Interestingly, though, if you actually look at those individuals, they tend to attend so-called steep fall clinics in London. There are about 5 clinics which had this fall, while the rest of the clinics in London, outside London, it was a straight line. And so that's interesting, these steep fall clinics. And if you look at our own clinic in Dean Street, you can see this massive fall in new HIV diagnosis. Why is that? Because these clinics are fantastic, all right? If any of you are up, got a train to catch, go to Dean Street. It's absolutely amazing. In the old days, you know, the clinics I used to have in the hospital were in the basement, hidden behind a door with a strange name. Now they're very, very open. This is the Dean Street clinic. You know, it's just amazing. You walk in like something from Star Trek. No doctors or nurses, it's all done with cameras telling you what to do the test, and you get your results, GU, HIV result 2 hours later. It's an amazing setup. And of course, these clinics really understand their populations. They understand what sex is like nowadays. They understand the new drug trends. There's no stigmatization associated with it. So if you look at these steep fall clinics, what we're seeing is not people coming in and being tested. We're seeing a whole load of repeat testers, people being tested 3, 4, 5, 6, 7 times a year, you know, because they're putting themselves at risk, they're coming back and being tested. And if you look at Dean Street, it's in the middle of Soho, in the kind of gay area, so people now go to Dean Street as part of their night out. You know, pubs aren't open yet, let's go and have a test kind of thing. So it's a really good thing that people are actually going and having regular tests. And if you look at the reduction in new diagnoses, if you look at the new diagnoses, you see that these are in the repeat testers, right? It's the repeat testers where this is happening. So if we're actually getting the diagnosis early, then there's less chance of them going out and infecting other individuals. So it's all about catching people early, and that reduces the transmissibility of the virus. The other thing that's happened within HIV, which has really helped, and you're talking about putting people on treatment and saying we've got these waiting lists, that's all gone in HIV. It's now about a test and treat approach. So people are being tested, found to be positive, and actually are being treated immediately. Right, or being offered the opportunity of being treated immediately. That means, again, we're getting people's viral load down very, very rapidly as soon as possible, so again the transmissibility goes down. So this is just the pathway. It doesn't really matter, the pathway, because it's all changed. And the last thing we have is a whole load of drugs. Right? We have a whole load of drugs, as you have a whole load of drugs, and we have a whole load of drugs which don't have toxicity. We have a whole load of drugs which work. And it's exactly the same for hepatitis C. You've got a whole load of drugs, but not much difference in price, really, if you think about your drugs are for 8, 12 weeks and ours are for life, really. And that all of these drugs are cost effective. So I think what we've realised in HIV is that we have all the tools. You know, we can get people tested, we can get them into care, we can get them into treatment, and we can treat them successfully. And actually, the big thing is all about access. Can we have access to treatments? Can we have access to care? Can we have access to testing? Thank you.